Good morning, everybody. I'm Emanuele Chisari. Thank you for Parvizi for the introduction. So today in my talk, I want to try to focus on the problem that we want to address today, and it's about the diagnosis of orthopedic infection. So I think that there are two main challenges, and the first one is about the shared infected patients from non-infected. And this is usually discussed in many meetings about which diagnostic definition is the most sensitive, the most appropriate, which biomarker is the best to use, what kind of clinical sign we should look for. But this is not really the topic of discussion. What we are talking today about is organism identification. The reason why this is important is because once you know that the patient is infected and you treat him, and you do the surgery, you try to identify the organism, then you need that organism identification to guide your management and also your antibiotic choice. Why is this important? It is important because we know from clinical randomized trial that were run by Rothman and also Rush, led by Dr. Della Valle, that targeted antibiotics reduce failures. But it's not only about that, it's also about antibiotic stewardship. We know that the bacterial resistance is on the rise. We will talk later about other mechanisms that can evolve out of antibiotic pressure, like resistance, which are another temable enemy in treatment of infection. So we definitely want to know which organism we want to fight and then which antibiotic is the most appropriate. But it's not just about this. What's happening is that for a long time, PJI are being considered mostly caused by staph aureus. And still, in many conferences, you always hear staph aureus makes up for over 50%, sometimes 80% of all the PJI. This, based on our data and emerging literature, is no more true. So we need to address the need to identify other organisms that are harder to grow in culture, like C. acnes, or supposedly called low virulence organism. In addition, if we don't identify an organism like a gram-negative, we are also missing the treatment target because we know from many studies that gram-negative have a high failure rate. So we need to know if the patients that we're treating is affected by an effective organism that is supposedly uncommon. So what we did is we tried to understand this in our home institutional database at Rothman. We did a review of all the two-stage revision coming from patients that did just a primary, so no history of previous infection, no history of bacteremia, no history of revision for a septic reason, just a primary, then developed infection, and were treated for two-stage. What happened is that 25% of first stages were polymicrobial, and overall, only 33%, so 1/3 of all patients, had as infective organisms staph aureus. So this again to highlight that staph aureus is no more just an holy organism. Now we wanted to go further and try to address all the trends in our institution database, trying to understand more about what kind of organism we are seeing in our institution. So in this graph, you will see that the line in blue is gram-positive, the orange line is gram-negative, the red line is culture-negative, and the yellow one is fungus. If we just focus on culture-negative, you can see that the culture-negative organisms are on the rise. So this is another problem, because when we don't have the microbial symptoms, when we don't know about which organism are we fighting, this makes us in a different position in terms of treating. So do we have a problem? Yes, we have a problem because we're not good enough at identifying the organisms that are causing the infections. And again, I want to highlight that all the data I presented is all about culture, so it's not using any of the sequencing technologies that we'll address later. I also want to go a step further and try to give a glimpse of the future and why this sequencing technologies might be a better solution. So if we think about bacteria, we should reconsider some dogma. And this is coming as back as Koch definitions of infection. And commensals, supposedly commensals, are not that different from pathogenetic. And from studies coming from different areas, we know that this is no more true. But even on an anecdotal experience, think about E. coli. That is a normal commensal of the urinary tract. But somehow, in some days, in some people, in specific times of their life, these people develop infection. Or Helicobacter pylori, that is another organism that is very often found in the gastric epithelium. But not every patient develops symptoms. Not every patient develops disease. Now, there is also another point. As suggested in the data that I showed earlier, that about 30% of all patients in two-stage treated in our institution were polymicrobial. But even if we look at the NGS published literature, we are already seeing that this number is constantly, in every case, about 10 to 15% of patients have polymicrobial. And actually, this number is probably an underestimation, because if we look at chronic of bacteria, where more virulent and low virulent infective organism collaborate to develop the infection. So this can never be investigated just by culture, because by the way it's done, it's very hard to identify multiple organisms using the same plate or the same plates. So what are the take-home message for my presentation? That pathogen identification is a critical factor if we want to think about the long-term success of the treatment and the tailoring of the antibiotic therapy. Staph aureus is still the most abundant organism, but there is much more. Like, it's not just Staph aureus. And actually, all the other organisms and culture-negative infection are on the rise. So we need to address these problems, because will become, and probably are already, common in the daily practice of all the revision surgeons that are treating infections. Thank you.
Thank you very much, Emanuele. Next, we're going to have Alicina give a talk about molecular taste versus traditional culture.
Alicina, are you able to access?
Are you able to access the talk, Alicina? If not, I think.
Hello?
Yep. Alicina, go ahead.
Okay, perfect. Just wanted to make sure that you can hear me. Good morning, everyone. Thank you very much for being here. And I'm going to go over culture versus next generation sequencing and what are the differences. Diagnosis of periparesthetic joint infection, PJI, is currently a very challenging problem. As you know, there is no absolute test. Hence, clinicians who encounter a suspected PJI case have to use a combination of tests, all of which, besides their expense, can be invasive, and even they are far from perfect. In 2013, the MSIs came up with a set of criteria for defining PJI, which was then modified by the International Consensus Meeting. And that definition also got modified in 20